Yeah, hi everybody. Uh, pardon me. I'm doing this relatively early in the morning, so my voice is not 100%. But what I wanted to do was to complete the large intestine and the digestive. There is not a lot left, since and this sort of takes the place of some of the material I was going to do on Monday, but we're doing that thing with Dr. Buxton and having some fun maybe in the lab after the exam and blah 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 blah. Nevertheless, large intestine. Moving along. And the large intestine is interesting. It when we get to physiology, not a lot happens there. Basically, you reabsorb water, maybe some electrolytes. It's something. It's effectively non-essential tissue. It could be removed in its entirety if necessary. We'll talk about that more in physiology. The three distinctive things that we see grossly, and it's something you might want to look for when we do this. I don't know how distinctive it would be when we do a fetal pig, but there are bands of smooth muscle, and there's three of them that keep the shape, which is very interesting. Keeping the shape of all of these of this massive amount, these roughly 30 feet or so, 20 or so feet of intestine that are there. This helps to hold them in their unique arrangement, as you will see. It also has these pockets, these individual segments are quite large. They're called haustra. Collectively, haustrum would be the singular. The first one of those is the cecum, cecum. That's where the ileocecal valve, where the ileum enters and effectively ends the small intestine, starts the large intestine, and the appendix sort of angles off of that, and if anything, points somewhat more centrally would be the way to describe it. And then there's these fat-filled pouches of visceral peritoneum. They're like almost like big drops. They're called epiploic appendages. Those are three important things anatomically to remember because they're the distinct, sort of the unique characteristics of the small. You'll see those. Affectionately, the first part is the cecum. That's large. Typically in animals, it's larger. It's almost like a secondary stomach. The appendix, which is lymphatic tissue. Okay, and again, it's part of that, as you can see, the mucosa associated, or malt or galt in this case. Its twisted shape is the problem. Because of that, and inherently that's the shape of it, things get trapped in there. That's when we begin to get particles. Basically, uh, think of it by and large, we think that this is really when people have colitis or really bad diarrhea, bad food poisoning. This replenishes their large intestine with bacteria, and the large intestine is an immense amount of bacteria. And so it's basic, I think, role number one, other than its immune function, is recolonizing the gut when these events occur. The trouble is things get trapped and people are more prone to appendicitis. Some more than others, some not at all. Well, sometimes you can get inflamed. And then again, the tendency now is to remove less immune tissue. We take out less appendices, less tonsils, because they're immunological tissue. I mean, if it gets to the point where it has to be removed, the problem is if it's ignored and just sort of it's a big bellyache, all of a sudden, it flares, and then you can get an appendix that has exploded. I have a very interesting anecdote about that, if you're interested, from what happened when I was a resident. So basically, the colon, they're all identical with the exception of the cecum, except there's a direction. You have the ascending colon, which goes up, starts with the cecum and goes up, basically on the right side, roughly to kidney level, and it's got a colic flexure. Okay, we call it the hepatic flexure because it's making a right turn, so to speak, at the liver. Goes straight across. That's the transverse colon, and then it makes another turn, another right turn, and we call that the splenic flexure because you're by the spleen, and that's called sometimes the left. I've always used the term hepatic and splenic, and then it becomes a descending colon. Oops, sorry about that. Then it becomes a descending colon, and then it basically makes an S curve because it's sort of peripheral, and now it's got to be centered, sort of with the end point of the alimentary canal. If you think of it going from the mouth to the anus in a direct line, and so it makes like an S-shaped curve, hence the name sigmoid colon, and basically into the pelvic area, and then at that point it gives way to the rectum. At the end of the sigmoid colon is when we make the transition again from simple columnar epithelium with goblet cells to stratified squamous non-keratinizing, because now it's really all about the rectum is all about finalizing and allowing feces to pass, when people basically have bowel movements. And then the anus is the external segment that opens up, and et cetera, et cetera. And they have a couple of sphincters. Internal is smooth muscle. External is basically the control that, when we have a sufficient amount of pressure, we either control it or we go when we have to go, et cetera. And this is a pretty good illustration. See, this is the unique thing about the appendix. And when you have appendicitis, basically it really is almost lower right quadrant pain that projects centrally toward the umbilicus. So and there's a thing called rebound tenderness when it's really sore. It means you press it, it's sore. Oh, that really hurts, and you let go of it because it's irritating the peritoneum, and it's like a rebound. It's kind of like basically a trampoline type of effect. And oh boy, so we call that tenderness of rebound. And I mean, it does not have the same structures per se. It's not. It's again, you're seeing peristalsis and you're seeing segmentation, but it's not that immense amount of swirling around with those circular plications. There's ridgings that are in there. That's all. And you can see all these segments. These are the individual haustrum. Collectively, we call it haustra. Here's that first one, which is typically larger. Here you can see these bands going around. And again, they're just demonstrating one of them, but it gives you an idea how it holds the shape. Because typically, aspects of the ascending colon and the descending colon are retroperitoneal. They're stabilized. The transverse certainly is not. That's there. And, and again, this is, you can see that's some of the ommenta that was coming down from above. And here you can see some of the, basically the connective tissue on the posterior wall from this illustration. Here you have the aorta, the abdominal aorta. You can see its bifurcation. So we're deep inside the pelvis at this point in time. And now you can see those epiploic appendages, etc. So it's a pretty good illustration. One undoubtedly will label for the final, but maybe I'll work on that today. And as it takes us in to the rectal area, you can see that, I mean, I don't care about these things, these comets. Just think of it as forming the feces. These relatively large veins are where hemorrhoids come from. So the cecum, the appendix, and the rectum are all retroperitoneal. They're kind of, think of it as being tacked down that are there. So that's an event when an appendix bursts, and this is part of the anecdote. What happened, the worst smell I ever smelled, was someone's appendix had burst. We weren't sure that it had burst, but the person was in just unbelievable pain, and there was basically going to explore what's going on because the pain was so severe. And I was working with one of our surgeons, and I was on an OR rotation at the time, so I was assisting everybody. And the guy, and it's like, oh, he's in such pain, the fever's high, and we have a suspicion there's a ruptured appendix. You open up, you couldn't see it. It had gone retroperitoneal and buried, and it had caused a massive anaerobic infection. If you emerge from micro, anaerobes stink. It's like all that bacteria in the incubator smelling like crazy. Anaerobic infections, I mean, rotten egg smell times 50,000. And we could feel it fluctuating, and the surgeon looked at me because I've seen these before. The appendix has probably gone in there, and we had gone in there with what's called a clean procedure, meaning that we were not expecting to find an open infection. We thought we were just going to take out the appendix because it was inflamed, acute appendicitis, cauterize it, close it, but no. So he said, I've got to open this up. He lanced it, and all of a sudden, pus just came out, this massive amount, and the smell was literally the worst smell I've ever smelled. The entire room became awful. And this is actual true thing, because it was known to be a clean case. At that point, the lady who was like the assistant head nurse puts a towel by the door to indicate it's a dirty case, because anything that's a dirty case, you don't want to contaminate other areas. You got to remove everything. And she goes, this is now a dirty case. And it's like, okay, we knew that, cleaned it up, fixed it up. I did well. Cleaned it out, bunch of antibiotics, et cetera, et cetera. After that, it was pretty much a slam dunk, easy end to the case. As we're walking out, you always leave your take off right in there because you're contaminated. You take off your all the stuff, your gown, your gloves. You strip everything off. You throw it in the floor in the wastebasket that's there where it's being collected. When she's by the door, she goes, "No." He says, "You're all contaminated. You have to remove your scrubs." We remove. Thankfully, a lot of times people wear scrubs without underwear. He and I both walked out in our underwear. Nearly the birthday suit effect. Oh my goodness. I can remember it like it was yesterday. And you go back and we're laughing about it. Oh my gosh. Something else. That's what happened. That was really because the OR nurses are it's like their territory. Heaven forbid you would contaminate or touch something, you were in big trouble. So as you can see, there's retroperitoneal, except mostly for its transverse and sigmoid. So it gives you an idea, as I said, ascending, descending. Cecum is part of that, the appendix, the rectum, and everything else. There's lots of this mesocolon, this sheets of mesentery. You can see it there. Don't get a lot out of that. Here they've reflected the greater omentum. You can see how it effectively surrounds. And there's a sigmoid sort of diving in deep. And now this is a better view of it when you sort of cut it away. You can see how the sigmoid is diving in deep like that. And that just when you're being, so here you can see where they point to sigmoid going sort of around the bend and then diving in like so. And that's actually a fairly good illustration. It gives you an idea of the role of all these mesenteries and how they envelop things, the distinction between the visceral and then the parietal that's there. And again, things that are back against the back wall, this is what we mean with retroperitoneal. Things like that. So, and you'll see when we get to the, pardon me, Pooch. Pooch is interested in something. When we get to the bladder and the kidneys, and you can see the rectum back here, they're all by definition retroperitoneal. The ureters are retroperitoneal, as you will see. And here's, we can read through this about appendicitis and things like that. Again, I'm not worried about the columns are part of it. I mean, all those crypts and things like that. It's sort of packing and folding the fecal material and the different, nothing like that. Really, if you're going to go into colorectal things, you're going to work in gastroenterology, you'll learn more about that type of stuff. Same illustration. And then this is, and again, this is more function than anything else. The importance, outnumber our own cells 10 to 1. The fermentation that goes on, it's less than what you think. People that just need people, depending on what they eat, depending on their individual metabolic activity.